Thank you to the organizers for inviting me to speak today. The HIV Care Cascade serves as a model to identify both opportunities and challenges related to the delivery of services to persons infected with HIV. The main stages or steps of the cascade, as we all know, include testing and diagnosis, linkage to care, initiating treatment with antiretroviral drugs, and achieving viral suppression. Evidence suggests that in sub-Saharan Africa, that dropout before, because of people not getting tested, between or within these stages remains a substantial problem. Based on a large meta-analysis, only between 10 and 30% of newly diagnosed HIV-infected persons remain in care long enough to start timely ARV. Furthermore, other evidence suggests that HIV testing rates remain at low levels throughout this region. It seems clear that improving the effectiveness of the care cascade will maximize the health gains that will be observed with more widespread accessibility to treatment, as there would be a greater proportion of persons infected with HIV achieving viral suppression. However, it is likely that such improvements will only be realized with the investment of additional resources. Numerous seek, test, treat, and link strategies have been studied across the continent, and multiple different approaches may be needed to achieve substantial gains in performance. Furthermore, these combination approaches may need to be tailored to the specific jurisdictions in which they will be implemented to account for variations in risk behavior, culture, and stigmatization. While it may be somewhat easier to estimate the number and cost of new ART regimens a national or regional entity may require in order to successfully implement a treatment as prevention strategy, the magnitude of investment necessary to improve enhancement of the HIV care services is much less certain. Given these challenges and uncertainties, we wish to use a simulation modeling approach to determine what would constitute a cost-effective budget for programmatic improvement of the HIV treatment cascade in the setting of ART expansion in East Africa. In other words, we ask the question, if we want to improve cascade effectiveness by a prescribed degree, what level of investment would be considered cost-effective? We modified a previously developed epidemic computer simulation model and modified it for the East African setting. Our model incorporates results from a microsimulation model of HIV disease progression and accounts for the transit between the different care stages, including diagnosis via testing, linkage to care, and ART initiation. For purposes of this analysis, we defined a construct we call the Cascade Effectiveness Index, which is simply the joint probability of a newly infected HIV person undergoing successful HIV testing and then being successfully linked to care. In our base case scenario, this parameter, which I will hereafter refer to as the CEI, was estimated at 11% based on regional data. In addition, we assumed optimistically that currently all patients in care and who have a CD4 count less than 350 would be initiated on ART. We then compared this to a multitude of scenarios where the CEI was varied with improvements ranging from 0 to 80%, and ART treatment was expanded to all persons who enroll in care and have who have a CD4 count less than 500. For each comparison, we then calculated a budget threshold by solving the incremental cost-effectiveness equation for the cost of any strategy, resulting in the improvement in CEI for a given willingness to pay. The willingness to pay values correspond to two commonly used international cost-effectiveness thresholds. Note that the solution to this equation in some instances can be less than 0. The interpretation of this situation is that no incremental or additional investment specifically aimed at improving the care cascade independently would be considered cost-effective. We began our analysis with a 20-year time horizon using a payer perspective and discounting both costs and health benefits at an annual rate of 3%. The outcomes we compared included QALYs, infections averted, and total costs in 2012 US dollars. The costs explicitly accounted for in the simulation included ART, routine care and monitoring, and morbidity costs associated with inpatient hospitalization. We conducted a sensitivity analysis to determine how the decision time horizon would impact these results. On this slide, we're looking at the base case results from our simulation, where the cascade effectiveness is not altered from its initial value. Expansion of ART access in line with recently published guidelines as to when to start therapy, is cost-effective in our simulation, as evidenced by the ICER of about $1,600. In addition, there's a modest preventative benefit that we estimate from our model. The following slides will examine the magnitude of investment that would be considered cost-effective if we expanded treatment eligibility in line with WHO guidelines and also improve the likelihood of patients accessing that treatment through improvements in the care cascade. This slide is depicting the budget threshold results for a 20-year decision threshold or decision horizon. Along the x-axis, the CEI is being varied as previously described. Along the y-axis is the average annual budget to be spent on improving the treatment cascade. The green data points represent budget thresholds that are equivalent to a cost-effective threshold within East Africa, whereas the blue data points represent those that are equivalent to the very cost-effective threshold. These figures can be interpreted in the following manner. For instance, assume a decision maker can budget no more than $50 million in a period of 1 year, in addition to all other costs, to enhance the cascade in this jurisdiction. A line emanating from this value, which intersects the data points, indicates that if this investment results in at least an improvement of 5% absolutely, he or she can assume that this is cost efficient. Greater improvements, this way, would also fall within this range, whereas lesser improvements would not. Alternatively, a decision maker may be assured that a given strategy will result in a robust gain in effectiveness, say, for instance, move the CEI to 40%. In this case, the decision maker can estimate an annual budget with which to spend on a program in order to achieve effective implementation, which in this example is about $150 million a year. Note that in this time frame, it would not be possible to reach the very cost-effective threshold. Here we're looking at a shorter time horizon of only 5 years. Note that both sets of data points fall within the negative range. This is observed because the health benefits gained in the comparison scenarios are relatively delayed in relation to the increase in costs. In other words, the costs of both treating earlier as well as improving the cascade performance through various implementation strategies are experienced up front, whereas the accrual of health benefits are delayed in comparison. Finally, we're looking at the same set of simulations evaluated at 50 years. In comparison to shorter time horizons, both sets of data points lie above the x-axis, suggesting feasibility for investing in a cost-effective manner. Furthermore, for a given budget or given improvement in CEI, the threshold for cost-effectiveness is higher, meaning that an investment that would have been considered previously inefficient at shorter time horizons may now be considered cost-effective. For instance, if we assume an absolute increase in CEI of 5%, and this can be achieved similar to before, spending up to $300 million annually would be defined as cost-effective, whereas at 20 years, this threshold would have been approximately $50 million. Key findings and conclusions from our work suggest that modest increases in overall spending directed at improving care, the care cascade may be considered cost-effective. In the example that I've used in the talk so far is that approximately $50 million US annually would be cost-effective given an absolute increase in CEI of about 5%. Importantly, efficient investment in cascade improvement is strongly dependent on the decision horizon. And this is because gains in quality and quantity in life are delayed in comparison to the incremental costs. Finally, further research is necessary to clarify the costing and effectiveness of strategies to improve the cascade of care in various environments, and in addition, to clarify the interactions between combinations of strategies on both their costs and their health benefits. Thank you.